Thank you. Next, I'd like to welcome up Dr.
Thanks, Liz. Thanks, everyone. It's great to be here. Today, I'm going to switch the gears a little bit. I'm going to talk to you about a pilot study that we conducted where we were trying to develop a tool for precision recruitment within healthcare settings. A little bit of background, or maybe I should have renamed the slide as why recruitment matters in research and across disciplines, because we know that recruitment is really the gateway to research, right? I want to begin by emphasizing that recruitment is not just a logistical hurdle. It's necessary, it's important, and it's foundational for us to really understand how we reach these participants, and when we reach these participants, how they're being represented. And recruiting efficiently and equitably remains one of the largest challenges in clinical and pop health research. And many studies often rely on a single recruitment method or ad hoc outreach approaches and diverse populations continue to remain underrepresented due to access, communication, trust, and logistical barriers. So this pilot project, we decided to test proactive recruitment strategies to identify scalable, equitable methods for broad research settings. Our objective was to evaluate the efficiency and equity of different approaches to participant recruitment in diverse settings and populations. We had 3 hypotheses, 2 where we were saying that outreach by mail phone will yield a more effective recruitment, will be a more effective recruitment method, have lower costs associated with it, and we will recruit people from underrepresented groups through mail phone. The last one was adding a physician endorsement from the person's healthcare provider would improve effectiveness of each research recruitment approach. So we set out by randomizing participants into 4 different intervention arms: a proactive outreach by mail or telephone, which included 2 weeks of mailings with a QR code, and so they could just scan the QR code, go to the self-administered survey, followed up by 4 phone calls over the course of 2 to 3 weeks. Then proactive outreach through MyChart messaging, where participants received a message through their MyChart portal every 1 to 2 weeks for a total of 4 messages. Again, all of this was self-administered, so they had access to links to their REDCap surveys. The third approach was unsolicited text messages, where participants received a brief text message introducing the study and providing them with a link to the REDCap survey. They could go onto the survey and take the survey, or they could say that they're not interested and refuse to participate. And the last one is IVR, or interactive voice response, where participants were receiving automated phone calls over the course of every 2 weeks for a total of 4 phone calls. They had the option of being transferred over to talk to a live research assistant, and so they can complete the screening and consent, or they could ask for a callback where a research assistant would call them back, or they could say that they're not interested. We randomized them into these 4 arms using the following randomization strata. And then, like I mentioned earlier, we did have an intervention modifier where we tried to see if endorsement from their PCP would improve their interest in research and participation in research. We included the following 5 studies: Bridge, Bump, Caregiver, ALTA, and ECHO. Bridge was an RCT of a diabetes prevention program tailored for older adults. Bump is a cohort of pregnant persons using cannabis and electronic cigarettes in any form. Caregiver examines the impact of caregiving on health. It recruits adults with cardiovascular risk who care for children, and then we also recruited some of their children. ALTA, which is an RCT of how remote monitoring affects trust. We recruited adults with uncontrolled hypertension. And lastly, ECHO, where we recruited from a previous birth cohort and from women who are currently pregnant. A few progress updates. I'm not going to go through all of this, but you can just basically see that we started recruitment across all 5 studies. We did start physician endorsement, but we didn't continue physician endorsement for 3 out of the 5 studies, and I'll talk a little bit more about why. I think this slide is really important. I think it gives a snapshot of the total recruitment activity across the 5 studies that we've supported so far. So you can see here that we had started with a total sample size of just under 6,000 participants. Total number of calls that were made through the IVR and mail call arms were over 4,000. And of the 4,000, our RAs made over 1,800 phone calls themselves to reach out to these participants. They also sent out over 1,800 mailers. And this last point, I think, is really, really important because you can really see the total number of RA hours that went in, or team effort that went into this for recruitment, quality assurance, logistics, trainings, intern coordination, IRB approval, workflows. I could go on, but over 800 hours that have been put in by our team so far. Preliminary results here. I think the main takeaway is that mail call yielded a better outcome in terms of completing screeners. So you can see that 12% of the participants in the mail call arm completed the screener, whereas 4% in the IVR arm and 3% in the SMS arm. Overall, completion rates were low, 3% total completion, 8% refusal, 34% unreachable, and we're still continuing our recruitment efforts, so 55% pending. I wanted to show the PCP endorsement summary table as well, because we did reach out to a number of PCPs for a total of 114 participants. And again, the overall efforts were quite low. You can see that 4% completed screener, 15% refused, 82% were unreachable. I still think this is a very important component and modifier that we had as part of our study, and we plan to continue to study this aspect of it. I think we just need to learn how to improve our contact and outreach to the PCPs. A lot of them, it was unreachable because it's really hard to get in touch with them. Arm specific challenges, like any study, we had a lot of challenges and limitations. I'm not going through all of these with you guys, but you can kind of see that my chart, recruitment in collaboration with DataCore, we had some challenges kind of kickstarting this. And excuse me, what we found was that DataCore cannot support sending two distinct messages, so with or without PCP endorsement. We also found, thank you. We also found out that each recruitment attempt requires a separate IRB, post-IRB DataCore request for my chart message setup. So every time we sent a message out, so for 4 messages, we had to submit multiple DataCore requests. And we can see that with IVR and SMS, they were both in collaboration with an external vendor called TeleAsk. That just required a lot of setup time. And mail and phone call, I'm sure we all know, it's quite labor intensive and time intensive, and requires great dedicated staff that we're lucky to have, but it requires a lot of coordination. Some initial challenges and lessons learned. We were working with multiple different groups within NYU. We were working with MCIT for security review, DataCore for my chart recruitment. We were working with TeleAsk for their assistance with the IVR and SMS. And then, of course, coordinating with the 5 different studies, their teams, their RAs, the PIs. We provided comprehensive support to these study teams. We helped with their IRB amendments, DataCore submissions, their database setup, pulling and cleaning patient lists, my chart setup, translation coordination, overall logistics. Our team also helped recruit in Spanish, so that required additional effort from our team. Some key takeaways from the study. So it was a huge effort to launch this pilot study, but we are incorporating the multiple recruitment methods. We want to incorporate these multiple recruitment methods across study teams for broader reach. And by testing recruitment, these strategies systematically, we know that it's going to contribute to meta research on what works, for whom, in what context. And what we found was that engagement is human-centered. We've heard a lot about AI so far. We haven't used any AI for this. We'd like to at some point, because we are expanding this hopefully to a larger study. But engagement so far, what we found is human-centered. Manual and personalized outreach continues to outperform automated and portal-based methods, which, I mean, frankly, it's understandable with the number of spam calls we've been getting. I understand why IVR was low. We also have learned that we need to really establish clear and strong protocols with each team, each multidisciplinary team that we're working with at project initiation, whether it's working with MCIT, DataCore, or the specific teams with the PI and their research coordinators. And recruitment is significantly more feasible with larger sample sizes. I mean, given the amount of logistical coordination that's involved for this study, it's just practical and feasible to work on larger sample sizes for if we're going to expand this. And lastly, some broader relevance and impact. Although this work was done within pop health, I think this can be applied across settings and across disciplinary teams with clinical research and health systems, where we can use this framework to really adapt test engagement in telehealth, follow-up visits, or cancer screening. We can look at behavioral and social sciences, where we can see how trust and personalization and communication mode could really impact engagement and participation in research. We can talk about data science and informatics, where standardized recruitment data could enable predictive modeling of response and engagement patterns. And lastly, from a policy and equity standpoint, we can use this evidence base to inform equitable outreach to increase investment in diverse and multilingual health system settings. Thank you.